Our community has been trying to use mutational burden as a biomarker for response to immunotherapies over the last 5 to 6 years, and it's been very conflicting results. We do have a tumor-agnostic approval of immunotherapy for patients with any cancer types whose mutational burden is 10 mutation or higher, as per Foundation medicine assay. But what we're really learning about TMB is that each tumor type has its own mutational burden distribution, and within each tumor type, different histologies may also have different mutational burden. So using a pan-tumor threshold for defining what is TMB high and TMB low can be challenging. Our group has recently tried to dissect this question in non-small cell lung cancer, which is one of the tumor types where mutational burden has been studied the most as biomarkers of response to immunotherapy. And through a multi-center design and leveraging 3 large cohorts of patients with non-small cell lung cancer who received immunotherapy, including a Dana-Farber Cancer Institute, Memorial Sloan Kettering Cancer Center, and the Stand Up to Cancer consortium course, we really learned that only patients with a mutational burden at the top decile are benefiting from immunotherapy or derive the greatest benefit from immunotherapy. So this study suggests that patients with this very, very high TB have high response rate, which is approaching 60%, but they also have higher progression-free survival, almost 12 months, and also a very longer overall survival, which approaching 34 to 40 months. This is particularly relevant because it's helping us redefining the optimal threshold for the use of TMB as biomarkers for response to immunotherapy in lung cancer. We also tried to understand why this very high TMB was associated with benefit from immunotherapy. We do know that the mechanism behind the TMB is the higher immunogenic load that can in turn elicit T-cells mediated anti-tumor responses. But to really dissect this question in our Dana-Farber institutional cohort, we tried to look at the immunophenotype of these tumors. And what we learned is that tumors with this very high TMB have also a significantly higher proportion of immune cells, specifically CD8 positive, PD1 positive T cells intratumorally, which are those on which immunotherapy tend to work. And so this is certainly an interesting and important correlative analysis because it suggests that immune cells are highly enriched, particularly in those tumors with a very high mutational burden. And so we hope that this study will support clinical decision because TMB is not routinely assessed. And so we really hope that this information can provide the community with a helpful biomarker that can help in treatment decision. And there are particularly settings in which this can be helpful because PD-L1 is an important biomarker for response for immunotherapy, as we know. And studies have tried to identify whether TMB and PD-L1 are collinear, meaning they go in the same direction, or they are totally independent biomarkers. Well, in this study, we did see that this very high mutational burden was associated with improved response rate, progression-free, and overall survival across different PD-L1 expression levels. So in PD-L1 negative, intermediate, and high. Negative defined as 0%, intermediate defined as 1 to 49%, and high defined as 50% or greater. In each of these 3 subgroups, very high mutational burden further discriminated responders to immunotherapy. So we hope that this biomarker can help also personalizing immunotherapy approaches in each of these 3 subgroups.